All right, I want to introduce our patient assessment process. This is a standardized process that we've come up with through quite a few iterations on evolution of thought over the last many years, and watching our students and how they experience the whole learning process of assessment. And this goes for both the EMT level as well as the paramedic level. And so we've decided that we're going to install this early on in the first session or two of all of our initial ed programs and integrate it into our continuing ed program. And we realize that there are many other assessment flow charts and things, and they're all very similar, but we've intentionally done it this way to make it easy to learn, easy to integrate, and particularly if you've never had an assessment process, this really helps you. And then if you have one that works, we want you to look at this and adapt to this rather than try to unlearn what's already been working for you. But we think that this is the way to go. So the full overview of this assessment tactic, as we call it internally here, involves these steps. There's an approach of the patient. There's that initial contact. Then there are initial actions, and what you find in the initial contact drives your initial actions. And then you get to a decision point early on, within seconds. Early on you get to a decision point. Then you go out and gather some information and gather some data, and that happens at the same time. Then you decide on your plan and you start taking actions. And then of course you continue to recheck, adapt, adjust, and work through the process. So this is kind of a linear, bullet-pointed version of the assessment process. There's really two things that you're doing, and one doesn't stop and the other one starts. So the initial approach and initial contact and initial actions, you're all in the resuscitative phase, and you may continue to do resuscitation while you do some investigation. One of the pitfalls that we've seen with learners in the past is that they jump into investigation before they've really covered all the things in the resuscitation phase. In many cases, you'll be able to move through the resuscitation phase quite quickly if your patient doesn't need any emergent interventions, but still this framework persists. And so the resuscitation does not stop at the red dotted line. Resuscitation would continue, then you would add investigation efforts on top of that. Here's a more flow chart, more visual depiction of it than just straight bullet points. And we'll go through each of these steps and then probably refer back to this screen a couple of times. So you have your approach, and that is basically, is it safe enough for me to come in? How many patients am I dealing with? Is this a trauma thing or a non-trauma thing or both? And then you do that initial contact sequence. And we intentionally stayed away from initial assessment or primary survey as labels because we want this to encompass all of those sorts of schemes and not be a reiteration of any one of them. So we're fairly intentional about our labeling here. Your initial contact involves that first check of CVO, of circulation, ventilation, oxygenation, and then that drives some initial actions that handle the life threats or begin to handle the life threats. And then there is a decision point and some communication about that. And then you gather data and info, and then you make your plan, and then you move on. So we'll come back to this probably, and we'll certainly use this in our classroom work on assessment. So the approach sequence, very quickly, is the scene safe enough to enter? The question is not, is it safe? Is it safe enough to enter? And you don't ask that question just once. You continually ask yourself that throughout your contact with the patient, and things may become more or less safe as time goes on. You would certainly want to know if you're dealing with one patient or multiple patients. That has to do with how you're going to assign your resources. It also has to do with the depth and the assessment scheme that you're using. But assuming that the scene is safe enough to enter, and there is just one patient, now we're going to consider, does this involve trauma? So you have a guy sitting in his chair in his living room watching TV having chest pain. You should consider that there might be some bizarre piece of this story where there is major bleeding or you do need to do C-spine control, but most of the time not. You should always consider it, but you certainly don't always have to do it, as opposed to the patient who's been ejected from a motor vehicle crash and is laying face down in the roadway. That clearly is trauma, and so we wanted to build that in your approach sequence, so that that's always there for you, even if many times you can move right on past that. Then you move to your initial contact sequence, and if your patient is alert, then there is not a need to also palpate his carotid while you palpate his radial pulse. But in that patient who is not alert, you do want to do carotid and radial. So in the patient who is not alert, who is responsive to voice or responsive to pain or unresponsive, there's airway management, airway control implications, and we also need a radial and a carotid at the same time. It would be silly, ridiculous, wrong, and bad for you to walk up to the gentleman in his recliner watching the ball game having chest pain and grab his carotid pulses along with his radial. So circulation, that the first thing, as soon as it is safe enough to do so, we need you on that radial pulse, palpating that radial pulse with appropriate PPE. If there is a need for gloves, okay, but with appropriate PPE. The touch of the patient matters. It's assessment and it's treatment. They feel better because you're there. So an appropriate body positioning, maybe down on one knee, but as makes sense for nonverbal communication and body positioning, and get a hand on that radial pulse. Now, what are you doing when you do that? Well, you are estimating their blood pressure by the presence or absence of that radial pulse and its strength. And you're also estimating the rate. You're categorizing the rate as too slow or too fast or okay. And you're also looking at skin color, and you're feeling skin temperature and skin moisture. So a circulatory assessment, a quick initial contact circulation assessment, involves radial pulse. Is it there or not? How strong is it? What rate is it? Way slow, okay, way fast. And then skin color, temperature and moisture, skin condition. This gives you a great idea of whether this person is perfusing adequately or not. Then you move on quickly to ventilation, and probably while you're still holding that radial pulse. It may be occurring almost at the same time. As you get better at this, a lot of these things happen concurrently as opposed to an isolated sequential step. But let's start with circulation and then hang on to that radial pulse. Look at how fast they're breathing. Again, Goldilocks sort of criteria. Too slow, just right, too fast. You're estimating, you're not counting, because you're doing this quickly and we're not going to slow down to count. We're estimating. In the next step, or in a future step down the road, we'll actually measure. So right now it's qualitative, it's an estimate. How fast are they breathing? Too slow, okay, too fast. Are they using extra effort? Are they breathing too shallow or extraordinarily deep? And then oxygenation. We want you just to look for cyanosis right now. This is not where the pulse oximeter comes out. That comes up shortly, but to apply the pulse ox right this second it's not part of the plan. So this initial contact sequence can be done and should be done with your hands, your eyes, and your brain, and not a whole bunch of other tools. We're not taking a blood pressure. We're not checking pupils. We're not counting a heart rate. We're not using a pulse oximeter. We're estimating. So one question would be, how fast does this have to happen? Well, I don't know. I think pretty fast is the answer. I don't think we want to tie a particular time frame to it. I believe that this can be done in most patients in 30 seconds or less, and in most situations, maybe even faster than that. And some of this even starts as you're walking across the room to the patient. You can see skin color. You can observe skin moisture to some extent. You can observe ventilation. You can observe sinuses. So it may be that I don't even know where to start the clock on this thing. It may be part of this you're seeing in your general impression during your approach. But really fast is the answer. How quickly should this be done? What's the time parameter and time benchmark? Fast. So let's explain pulses here a little bit. And I already kind of touched on this. So we're always going to palpate a radial if that patient who is not alert, who is responsive to voice or responsive to pain or is unresponsive, then we're also going to add a carotid pulse at the same time. And this is so that we can go fast. You're looking for the presence or strength of those pulses. To estimate your BP, people should have radial pulses. If they don't, they have a bad blood pressure. We don't know what the number is, but qualitatively, we know that they have a poor blood pressure. And then a rate estimate, again, too slow, normal, or too fast. And then as you become more experienced at this, and probably for advanced providers at the paramedic level, you're probably adding regularity of the pulse in there as well. But after some debate, we decided not to include it specifically in this sequence because there isn't anything that you would do immediately, urgently, and at the BLS level that would have any impact on anything if you found an irregular pulse. An irregular pulse may be a normal situation for that person. So advanced providers, yeah, we're fine with that. You can be thinking it, you can add to this, but you can't slow down. So that's the thing. Ventilation, we already talked about this a little bit. You're estimating that rate. You're looking for that extra effort. Are they working to exhale? Patients should not have to expend energy for expiration. Inspiration is an active process that does require energy, but exhalation is simply relaxing. If that patient is also having to expend energy and work to exhale, then they have increased effort, increased work of breathing, and that factors into our ventilation assessment. And then we're also looking for the use of accessory muscles. And while this may be obvious to you in the very short of breath patient, we want you to intentionally look at it in all patients. All patients should be using their diaphragm, but they should not normally, in normal situations, be using their neck muscles, their intercostals between their ribs, or their belly muscles, those accessory muscles. Now, say a person with chronic lung disease, a person who has emphysema and uses accessory muscles all the time, well, that may be a normal variant for them. And so we're trying to find out what's new, what's different, and where we need to intervene. And then we're also doing depth on a Goldilocks scale, where we're saying it's too shallow, it's normal, or it's deep. Once you have completed your initial assessment, your initial patient check, and you've looked at CVO, now it's time to fix those immediate life threats that you find and fix those right now. If the patient has an open chest wound, we need to deal with that now. We should not be gathering information and data. It would be absolutely absurd to check his blood pressure while he has an open chest wound. It would be absurd and wrong to ask about allergies and meds and past history. So we need to get on that right away. At the BLS level, we're going to seal an open chest wound. At the ALS level, we may seal one and then make another hole. So look for holes, seal up the holes, and at the paramedics, if you need to make a hole, now would be a time to do that. If this is a cardiac arrest, this is where we figure it out, it's where we start our actions. And so in a previous iteration of some of this assessment stuff, we had talked about first step, is this a code? And we've decided to move it in to this point because we want you to do CVO even in an arrested patient. That should be quick. It should not delay you, but we want to start the same way every time. But if we are working a cardiac arrest, now's the time to start working that. And so then you would almost branch off of this into the separate CPR, AED sequence, and this and that. You may need to control the airway right now. Certainly if your patient is not alert, if they are responsive to voice, pain, or unresponsive, airway control is almost certain to be needed. It may just be positioning, it may just be jaw thrust, or it may go further into advanced airways. And the same with beginning ventilations. If their rate is a problem, or their depth is a problem, or if their work of breathing is such, you may need to jump in and ventilate now. You don't know exactly what's wrong with this patient, but you know that something big is wrong with this patient, and you got to get going on that right away. So these initial actions happen prior to gathering information, understanding field impression, field diagnosis, list of differential diagnoses. It occurs early on, and this is the step where it occurs. Then also on the ALS side, paramedics may do transcutaneous pacing, synchronized cardioversion, needle chest decompression. They may at least put the electrode pads on. And again, we want to show everybody everything here in terms of an assessment framework. And so there's nothing wrong with EMTs knowing that this is what the medics will do if they're in your position. And certainly we want to be trying to train both levels at the same time. So now you've gotten to this first decision point. Have you found a life-threatening issue? Is this a critical emergent patient? In many cases, that also means that emergent transport is indicated because the proper management of a critical trauma patient involves emergent transport almost over and above anything else. But certainly is one of your top 2 or 3 things to be doing. You need to keep them ventilated, keep their airway open, try to support their circulation, but the ultimate fix is emergent transport. We are absolutely not suggesting that you just panic and say, let's just go, anytime you find something wrong in that initial check. But sometimes, if you have a critical trauma patient, then emergent transport is indicated right now. And one of the first critical actions that you would communicate and direct would be, we need to get this, this, and this, and we need to be transporting emergently. And so it's also important that you communicate. And I personally struggle with this from time to time. I recognize that the patient is very sick, and I somehow assume that everyone else has seen what I've seen. And so it is important that you communicate and you express, so we have a critical patient condition here, and here's what we need, and list those things in the order that you need them done. And in many cases, as the team leader, you would start giving directions to execute those things. So then the next thing that happens is either gather data or gather info. So I'm going to skip back to our more schematic version here. And we've come through the approach sequence, the initial contact sequence. We've done CVO. We've done initial actions to deal with those life threats we've identified. And we've come to this decision point and decided, is this a critical patient and a critical patient that needs emergent transport or not? And then we're going to do 2 things at the same time. We're going to gather data and gather info, or gather info and gather data. And so when you put something like this on paper in a 2-dimensional sort of flow chart, you're kind of trapped into some things. We want you to realize that we're gathering data and we're gathering info, and those 2 things can happen at the same time. Gathering data, what does that mean? Well, it used to be that we would let students get by with saying, well, I want a full set of vitals right now. And that's been insufficient, because those may come in the order that they don't want, or it gets them that they don't need. It introduces confusion and delay, and we don't want that. So here we're going to be very prescriptive. Very prescriptive. We're going to do this in this order. We're going to get a pulse ox first. That's quick and easy. It's one thing that goes on their finger. It gives you some heart rate indication as well as O2 saturation. Put that on first. Even if you're coming off the ambulance with a cardiac monitor that's got gazillion things that you can do off of it, put that pulse ox on quickly and then work on the next thing, because it's just one wire. It goes on one finger, and that finger is easy to get to in most cases. Then the next thing down is that on the ALS side, they're going to want limb leads, the 4 wires, the first 4 wires, the ones that go on each of their arms and legs. Get those EKG limb leads attached on the ALS side. EMTs working in a BLS first response setting, just know that if you were a medic or a medic was there with you, they'd want the limb leads on now. You can't do that. You don't have them. You just move on. So then blood pressure happens next. We want to measure that blood pressure. We've estimated it during the initial contact, but now we want to measure that blood pressure. We would like it by auscultation, so we get a systolic and a diastolic. If we can't hear, then we have to feel, and then we'll get a blood pressure by palpation. If we have a blood pressure machine, that's wonderful, but we want a manual measurement first followed immediately in the same arm with the machine blood pressure. We want to know if we can allow the machine to do its thing. We want to know if we can trust the machine's numbers. The machine doesn't forget to take it every X number of minutes, whatever you set it at, and it doesn't forget what it got. So the machine blood pressure is great. We need to do that manual thing first. Then we're going to physically count the respiratory rate and consider lung sounds. Not everybody needs lung sounds at this point, but this is where it would fit in. And then there's other stuff. Some of this you can do at the BLS level. Some would have to be at the ALS level. Those are starred. While it is possible for a BLS service to have end-tidal CO2 and capnometry measurement, that typically comes with the ALS monitor. Same with that 12-lead EKG. So again, to kind of go back through some things here, the first thing we need is O2 saturation, and that's because the use of the pulse oximeter gives us both O2 sat and heart rate visual indication and measurement. It actually counts it. So as long as you validate that the blinking light or the waveform on the pulse ox matches the patient's pulse rate, then you can allow the machine to do the math and do the count for you. Plus, in many cases, it gives you an audible or at least visual indicator of what the heart rate is doing while you move your hand from the radial pulse to other areas and start doing other things. So that's the first thing. Then medics would want the limb leads attached, and they would not want a 12 lead here. They would want limb leads first. To come in and do a 12 lead first is silly. Then you need that blood pressure measurement. Then you need an actual respiratory rate count. Consider those lung sounds, and then add other stuff in. If a glucose is appropriate or a temperature is appropriate, maybe a pupil check's appropriate. That other data happens right here. So this is the gathering of data. And many times, some or all of these will be outsourced to assistants. If a paramedic walks in to see a patient and has 3 assistants who can start gathering data, the first one should get pulse ox, the second one should get the limb leads on, the third one should get the BP measurement, and then the guy that's got the pulse ox should then count the respiratory rate and consider listening to those lung sounds, or else the team leader does that, and then the team leader would request or direct that maybe a glucose be checked, or a temperature be checked, or pupils be checked, or the additional ALS parameters be added on. So in the context of the team leader and helpers situation, kind of the ideal thing would be that the team leader has so many helpers available to them, they're able to do all of this stuff very rapidly. But the team leader then needs to gather all that data. They're rarely making a decision based on just one measurement of one parameter. Gather all that data and add it to the info that they're going to gather. And so the data and the info are occurring at the same time. This is history and physical. History and physical. So what we don't want is to start our history gathering with, sir, do you have any allergies? Do you take any medications? Do you have any past pertinent medical history? And so you're basically just working down the acronym of sample history with no real thought as to what the information means. You're just asking questions and writing down answers. We need to get away from that. We can be much, much better than that. A rapid trauma exam or a focused physical exam or a head-to-toe exam would occur at this point. And the deal there is that if you found an open hole in the guy's chest in your initial contact, one of your initial actions is seal up that hole. That is a life threat. That alone makes this guy a critical emergent transport critical trauma patient. It doesn't mean we found all the life threats. It means we found one, and it only takes one to trigger that critical emergent transport. Now we need to find all the rest of them. So that's your rapid trauma exam. And we'll excerpt several of these things and make them their own little sequences that we practice until we can't get it wrong. And then we put all these sequences together into this overall tactic. I'd also want HPI right now, the history of the present illness, which would include some mechanism of injury, nature of illness, the situation, what's going on, sort of stuff. And then I want to know past history. That's pertinent. Not all of it. We don't really care particularly about the ingrown toenail that you had surgically removed when you were 9, but the pertinent past history and the meds. And so we're gathering data, we're gathering info, and whereas the initial contact and initial action should occur within seconds, this part may take a little bit longer. Sometimes it's really quick, but it may take a little bit longer. So I'm going to gather data and gather info. I'm going to go back to this again. Okay, so quick initial approach, initial contact, initial actions, that initial decision. Then we're going to gather data and gather info. Here's where we're trying to gather the information we need to figure out what's going on with this patient. What's his primary problem? What's his second, third, and 29th problems? What are our priorities? We can make a decision on a patient care plan and then start taking some action. And so that comes during the gather data and gather info. And again, I will come back to this, but I wanted to throw it in for sure. Remember, sample and OPQRST are acronyms to help you remember the whole list. We would never, ever, ever intended for you to ask them in that order, and rarely is that the appropriate order to ask them in. Ask what's pertinent and do this sort of questioning with a purpose. Once you get your data and your info, now you're going to think. You're going to determine what you think is going on and make a plan to help it get better. Yes, you're going to match patterns. You're going to recognize previous patterns of calls that you've been on and types of patient conditions and presentations that you've learned in your education. You're going to pattern match. The danger in that is that, hey, you say, this looks like a call I went on last week, or this sounds just like a scenario we did in class. Okay, it can sound like that, but rarely are they identical. And so be careful that you don't have tunnel vision. Pattern matching and pattern recognition is wonderful, useful, a tool that we promote and advocate and want you to use. But we need you to avoid tunnel vision. Remember, they can have more than one thing wrong. Patients don't read our textbooks, they don't read our protocols, and they have the sheer audacity to have more than one thing wrong at a time. So we need to try to find all the things that are wrong, form a list of those, and then make a priority action plan to address them. Don't be fiddling around with a tib-fib fracture when the guy's got a hole in his chest and is in shock. Let's make sure that we consider checking a blood glucose on our altered mental status patient. But if he's not breathing adequately, we need to start working on that first, rather than stand and watch him snoring and not ventilating while we check a blood sugar to determine that he is hypoglycemic, and that's why he's not ventilating well and not managing it. We need to jump in and start doing things in priority. So, next topic there. We want you to pattern match. We want you to recognize. We want you to jump to a conclusion. Here's what I think it is. And then it might be some other things, and then I need to try to prove myself wrong. If you will work diligently during your execution of your treatment plan to continue to do assessment and continue to probe and make sure that you're getting it right, your patients will get the best service possible. And then always reassess, rethink, make adaptations and adjustments. And so how often do we reassess? Well, we constantly reassess. We reassess as often as is needed so we don't mess this up. It's important that we get this right. So this is kind of our overview, and we're going to break this up into chunks and excerpt out various sequences and work on them until we can't get them wrong, and then put them together. And this is really what we do, whether at the BLS level or the ALS level. It's the same thing. We add some stuff in on the ALS side. We add a tremendous amount of background knowledge and a much richer database of patterns for which you can match and recognize. But it's the same assessment process, and so we wanted to go over it and talk about it, and we're excited to launch this early in our initial education programs and roll it out in our Con Ed.